University of Cincinnati College of Medicine. Dr. Ryder specializes in head and neck cancer and nuclear medicine therapy. She has contributed to many publications on thyroid cancer. Dr. Ryder is a 2007 ThyCa Research Grant recipient. Welcome, Dr. Ryder.
Thank you. Thank you very much, everyone. I'm sorry I can't be there in person. I was a Texas girl for many years and would have loved the opportunity to be back in Houston this weekend, but I had overlapping meetings here in Minnesota and couldn't be at both. So I'm privileged to be able to join virtually. I have two sessions, and the session today will be discussing how we follow patients with thyroid cancer after their surgery and with or without radioactive iodine. So I am an endocrinologist, trained in endocrinology, but I do have a joint appointment in oncology. So I do treat the spectrum of thyroid cancer from the lowest risk to the most advanced disease. And it's such a privilege every year to be a part of ThyCa. I think this is the most exciting conference because you, the patients, are really what we're here for, and what our efforts and work in the clinic and in the lab is to improve outcomes for our patients with thyroid cancer. So follow-up is an important part of thyroid cancer. And so I have no disclosures. So we'll dive in. And I think I have plenty of time for questions at the end. So feel free to ask and write down your questions as we move through. So when I think about thyroid cancer, I like this new WHO 2022 sort of classification of thyroid cancer because it really follows a phenotype-phenotype or phenotype-genotype pattern, which means that we have on here the left classical papillary thyroid cancers, which are primarily driven by BRAF or BRAF-like mutations and their different subtypes, to the middle columns here, which are RAS-driven tumors, which are really like follicular thyroid cancers, or I say follicular patterned lesions, which have a distinct biology. And then we have poorly differentiated and oncocytic or Hürthle cell thyroid cancers. And somewhere off here would be anaplastic thyroid cancer. So this really classification really can predict clinical biology and features of cancers. And I've recreated this in a cartoon. When I think about thyroid cancers and I see patients in the clinic, I think about the BRAF-driven cancers and the RAS-driven cancers. Here, the BRAF-driven classical PTCs, many are low grade. They have expression of NIS, the sodium iodine symporter. They express TSH receptor and thyroglobulin. But as they acquire additional mutations and become more advanced, they often lose these thyroid gene expressions, including the TSH receptor, NIS, sodium iodine symporter, and produce less thyroglobulin. This is in contrast to follicular patterned lesions, the follicular thyroid cancers or the follicular variant PTCs that are invasive. These RAS-driven tumors produce lots of thyroglobulin typically. They express NIS and often are iodine avid, and they likely retain expression of TSH receptor. Poorly differentiated thyroid cancers, which are also RAS-driven, really do not express NIS well. They may not produce thyroglobulin well and may or may not still express the TSH receptor. And then oncocytic thyroid cancers, formerly called Hürthle cell, we used to think of these as a subtype of follicular thyroid cancers, but they really are different. They produce lots of thyroglobulin, like these follicular patterned lesions, but they really are radioiodine refractory, but appear to likely still express TSH receptor. And these features will be important in my next talk and in this talk when we talk about surveillance and follow-up in terms of when do we see patients back and what imaging and labs do we rely on for follow-up. So understanding this sort of classification, genomics, and clinical biology can help us understand disease and understand how to follow up patients. So we've evolved from a one-size-fits-all with total thyroidectomy, radioiodine, TSH suppression, and surveillance to a risk-adapted approach where for low-risk disease, we ask what treatments are of limited benefit and maybe even harmful. and intermediate risk disease, what therapies can reduce recurrences, and in advanced disease, what therapies improve survival and outcome. And for this talk, I overlaid, importantly, what is the follow-up for patients in these different risk stratifications. And dynamic risk stratification has been well described and outlined by Dr. Tuttle at MSKCC, and this is a figure from the manuscript talking about dynamic risk stratification. This really starts at diagnosis with your ultrasound and additional imaging and the biopsy, which can influence your approach to surgery and adjuvant treatment. And then the risk stratification continues through follow-up. And it's reassessed in terms of, is there an excellent response or is there incomplete responses with persistent thyroglobulin or persistent structural disease or intermediate assessments. And all of these influence really what follow-up is. And it's not necessarily now a one-size-fits-all, but a risk-adapted and individualized approach to follow-up. So I find cases helpful. So I'd like to walk through a few cases to just highlight how I think about initial approaches, which also impacts surveillance and follow-up for patients. So this is a 41-year-old male who had an FNA-proven papillary thyroid cancer. Here's the nodule here. And he had a small suspicious lymph node. These were all probably about 7 to 8 millimeters, under a centimeter. And this is the cartoon rendering from our radiology department. He's got this probably 3-centimeter PTC and several suspicious lymph nodes. So in terms of our risk stratification, we'll go back to this dynamic risk stratification and enter in what we think is his AJCC risk assessment along with ATA risk for recurrence. The staging helps predict risk for death, while ATA risk stratification predicts persistent recurrent disease, which is often the most helpful because outcomes for most of our patients are excellent. So in looking at this patient, I would assess him as low to intermediate risk for recurrence, but with an excellent survival. I say low to intermediate risk because of these small lymph nodes. When you have more than 5 or 6 lymph nodes, we know that there may be, after comprehensive surgery, a 10 to 20% risk of recurrent lymph nodes in the future. Although with comprehensive surgery, because these lymph nodes are small, his recurrence rate might actually be reasonable and low. So our options based on our risk assessment with excellent survival, but potential risk for recurrence may include anything from lobectomy plus nodal dissection, to total thyroidectomy and postoperative radioactive iodine. And all of these strategies can be considered as either standard of care, which generally might be today total thyroidectomy and possible post-op radioiodine, versus an individualized patient or provider tailored approach where lobectomy plus nodal dissection might be sufficient for that patient, or preference for the patient based on patient and or provider preferences. And whichever approach we choose will impact the future surveillance. And so we talk about that upfront, what surveillance looks like, whether we do a standard of care or an individualized approach. So this patient did undergo a total thyroidectomy. The path revealed multifocal classical papillary thyroid cancer, was 3.1 centimeters with extension to the strap muscles, and 7 lymph nodes were positive, the largest being 1 centimeter. So the next follow-up for this patient after surgery is, do we elect radioactive iodine ablation? This is to kill any microscopic residual disease that's left behind. We call that adjuvant therapy. Or do we go immediately into surveillance? And if we do surveillance, when and how do we do this? And does the treatment with adjuvant radioactive iodine impact our surveillance plans? The nice tools that we have today is that pathology is digitized. And so it allows me as an endocrinologist to look at the pathology for a patient and see what the pathologist is describing for me, but sometimes doesn't always come out across clearly across all path reports. So this is this patient's thyroidectomy specimen, where while I'm not a pathologist, after multiple tumor boards over the last 10 years, even I can recognize that this looks like a classical papillary thyroid cancer. What I'm reassured by, perhaps, is that there's a lot of colloid here. Colloid is the space where thyroglobulin and thyroid hormone is generally stored, and it's generally a good sign when I see lots of thyroglobulin. It suggests a very thyroid-like type of thyroid cancer. I can't quite see any tall cells or things that look more aggressive. But again, it's just my tools to supplant, to help complement the pathologist when I can see the pictures. It's a nice addition. So thinking about this classical PTC that I think is somewhere up here, and thinking about risk stratification and surveillance, this to me is a classical PTC. It's a low risk histology. It's likely to be a good thyroglobulin producer, and the risk for distant disease is probably less than 3 to 5%. Most of the recurrences for this type of classical PTC are lymph nodes in the central or lateral neck. And so I can rely on thyroglobulin and ultrasound screening to detect these recurrences over treatment. And importantly, these recurrences, when they happen, are very readily amenable to treatments with either alcohol ablation that we offer here at Mayo, or reoperation, or sometimes even surveillance. So this patient elects, based on his pathology, to undergo remnant or undergo adjuvant radioactive iodine therapy. Sorry about that. Here we go. He received 125 millicuries of radioactive iodine. And his iodine whole body scan is shown here on the left, and the post-therapy scan is here on the right. There's no uptake in the lungs, which either means two things. There's either no disease or there's disease, but it doesn't take up radioactive iodine. When we do our SPECT CTs or iodine whole body scans, we do use SPECT CT, which means we get images of the lungs. And this is just one snapshot of this patient's lungs, showing that there are no lung nodules. The most likely next spot, if this cancer is to spread to the lungs, is to the lungs. So I'm pretty confident that this patient has had a comprehensive surgery, has had a dose of adjuvant radioactive iodine, and doesn't have distant disease. So my risk stratification is that this patient will do well. And so my follow-up for him is I'm expecting an excellent response to therapy, maybe indeterminate. I will grant some folks that because of the extension to the strap muscles. And I would see this type of patient back probably in 9 to 12 months, although some might choose 6 months. And I would do a neck ultrasound, TSH, and thyroglobulin. And I'm making an assumption that my thyroglobulin will be useful for this patient based on his histology. And indeed, on follow-up, at 1 year follow-up, the patient had small but suspicious lymph node in the right lateral neck. We followed that given its small size and non-threatening location. And a year later, there were additional small suspicious areas in the right lateral neck. We biopsied them, and curiously, the FNA was negative. I didn't quite believe it because the lymph nodes look very suspicious to me. So he underwent surgery in November 2015. Comprehensively, 22 lymph nodes were removed and only one was positive. His thyroglobulin is 0.2. So he went back to probably annual follow-up, and from 2016 to 2022 has done very well. He still has a detectable TG, though, at 0.2, and he does still have one suspicious area in the right lateral neck that hasn't changed. So my dynamic risk stratification for him is that he's had an excellent response to therapy, although some might argue that he has an incomplete biochemical or incomplete structural response because of this suspicious node. His most recent imaging was stable in 2022. He's now many years from his initial diagnosis and recent surgery. So I see this patient now every 18 months with a neck ultrasound, TSH, and thyroglobulin. If his thyroglobulin had been 0 or undetectable and the ultrasound completely clean, he would have been able to graduate from my follow-up to his local primary care without the need for ultrasounds, but with just neck exams, TSH, and a thyroglobulin yearly. So again, we look at the phenotype of the disease, understanding what the genotype will be, look at the outcomes of pathology and our follow-up to determine risk stratification and long-term follow-up. So let's change to this next case. This is FNA-proven 1.5 centimeter right thyroid PTC that was found on exam by the patient in February 2019, underwent total thyroidectomy, near total with Dr. Leiden, and had multifocal disease, no lymph nodes and no distant disease based on just clinical staging. Patient did not receive radioactive iodine therapy. So what is the risk assessment for this patient and what is the follow-up? So this is another classical PTC. Most PTCs recur in the neck, and usually we can rely on ultrasound and TG levels. So this patient is very low risk for recurrence, excellent survival. Surveillance would be annually for 3 to 5 years, and then graduate after 5 years. At our first ultrasound a year later, her TG is 0.5 to 1, neck ultrasound is negative. Her risk for recurrence after this 2019 to 2024 follow-up, about 5 years, is now less than 2 to 3%. And so we can graduate this patient back to their primary care for just a neck exam, TSH, and a thyroglobulin, ideally. We no longer necessarily need neck ultrasounds every year unless there's something clinically, either by exam, you feel lumps or bumps, or by symptoms. There's changes in voice or difficulty swallowing, or the patient feels a lump in the neck. So I'm going to switch to a more unique case, not standard of care, but how we still use risk-adapted approaches in our follow-up. This is a 45-year-old gentleman who presented with a hoarse voice to the local ENT physician and was found to have a right vocal cord paralysis in 2023. A CT neck showed a thyroid nodule. If you can see that on the screen, it's here in the posterior right lobe. It happens to be in just an inopportune location, or not a great location. Here's the thyroid, here's the esophagus, and the recurrent laryngeal nerve running in this space. So it was unfortunate, the location of this thyroid cancer. FNA of this nodule was positive for papillary thyroid cancer, and the team at home did a CT chest of his lungs and found no suspicious lung nodules. And on ultrasound, this is the PTC here. It's kind of a classic PTC. It's very dark, might be a little bit taller than wide. Looks like it has echogenic foci, and we can see some potentially irregular margins here. It doesn't look like the most aggressive PTC that I've seen, and the ugliest. And again, I think it happens to have bad luck in its location, but certainly does have some extrathyroidal extension. So what is this patient's risk for recurrence, and what are the next steps for this patient? By staging, because of invasion to the recurrent laryngeal nerve, this would be classified as a 4A. N0 or NX clinically preoperatively, and M0 based on that negative CT chest. So estimated based on his age, stage 1, associated with an excellent survival, but clearly maybe an increased risk for recurrence based on the extension to the recurrent laryngeal nerve. So his estimated pre-op risk is intermediate to high risk for recurrence locally, likely excellent survival based on staging. Options certainly include standard of care, total thyroidectomy and radioactive iodine adjuvant treatments, which is probably what most endocrinologists would take. But there are non-standard individualized approaches as well. And so ultimately, standard of care versus an individualized approach is the discussion with the patients at the clinic. And whichever approach we take here impact surveillance options down the road. This patient did undergo surgery, and just like the last patient, has a classical papillary thyroid cancer. I see a little bit less colloid than the last case, but I do see colloid. I don't see tall cell features or high risk features, and it was the pathology reported classical PTC. There was invasion of the recurrent laryngeal nerve. It was multifocal. And so the question for this patient is, what is the next step? and how this impacts surveillance. Would he get total surgery plus radioactive iodine? And I will say this patient actually elected an individualized approach. He underwent lobectomy with ipsilateral central compartment nodal dissection. Final pathology was a papillary thyroid cancer with invasion to the nerve. He elected not to do a total thyroidectomy because of the uncertain benefit of radioactive iodine, even though, oh, there it is right there, even though radioiodine is often the standard of care for locally invasive disease. So he elected lobectomy with ipsilateral nodal assessment. He understood that with this approach, we would need more regular surveillance for him because he may have increased risk for recurrence. And at 1 year, so our surveillance for this patient, because we elected an individualized approach, is 6 to 9 monthly ultrasounds. I do include a CT neck because I want to see this TE groove, and this may not always be visible on the ultrasound. We'll do a TSH, and I do baseline thyroglobulin levels, which started off at 4s and have gone down to 2s, understanding that he has an intact lobe, and there's no data that the thyroglobulin will be helpful in this setting. But I like to look at it and see what the trend is. A year later, he has no evidence of disease on ultrasound, and as well as on CT scan. And so we're continuing our 6 to 9 monthly follow-up for the next 5 years. And at 5 years, if he's not had a recurrence, we'll be reassured and we might move to still continuing imaging, but on a 9 to 12 monthly basis thereafter. And so it's important to note that if we're taking a non-standard approach, as in this case, that surveillance will be more frequent. And this must factor into the patient's schedule, their travel. This patient actually lives in Arizona and travels to Rochester for these scans. And so it's not a trivial thing. And we had very careful discussions about this before we elected this individualized approach, because I'm already thinking about what surveillance looks like. So we'll pivot away from classical papillary thyroid cancers for a moment and talk about RAS-driven tumors, because these do have a different biology than the classical PTC. These RAS-driven tumors are primarily the invasive encapsulated follicular variant PTCs and the follicular thyroid cancers. They're driven by RAS mutations. And these tumors, again, tend to be very good thyroglobulin producers. They tend to retain expression of NIS, at least initially, and TSH receptors. So they're responsive to TSH suppression in advanced disease. Their pattern of spread, however, is different than thyroid cancers. They don't tend to recur locally in the neck. They tend to spread via the bloodstream distantly to the lungs and the bones most commonly, but can travel other locations. So these are not typically local recurrences. So when we think about follicular patterned cancers here, they're stratified as minimally or widely invasive, which is an important distinction because these are very low risk cancers, whereas these are higher risk for recurrence and distant disease. They're good TG producers. Again, they tend to be iodine avid, less commonly recur in the neck, and when they spread, it's most commonly to the lungs or bones. And so this is the cartoon of what we see, or these are histologies of what we see for follicular neoplasms. On fine needle aspiration of this type of nodule, it will come back indeterminate, called a follicular neoplasm. And these are sheets of cells arranged in this microfollicle architecture. What determines this as cancer versus adenoma and no cancer is whether there's invasion of these follicles or thyroid cells through the capsule, as shown here, or into blood vessels, not shown. If there's no invasion through the capsule or through blood vessels, this is a benign adenoma. If there is invasion through the capsule or into blood vessels, this is a follicular thyroid cancer or an invasive follicular variant thyroid cancer. And then we determine the degree of invasion. If it's just in the capsule and less than 4 spots of capsular invasion, it's called minimally invasive. But if there's blood vessel invasion and greater than 4 spots of capsular invasion, it's widely invasive. And if there's mitosis and necrosis, it's a high-grade lesion. So depending on which stratification this is, determines risk for recurrence and types of surveillance. And certainly surgery is the gold standard to understand this. And although this risk stratification, I think, primarily applies to papillary thyroid cancers, we can still use it for follicular thyroid cancers in assessing response to therapy and reassessing their response to therapy on follow-up with thyroglobulin and imaging studies. So for follicular thyroid cancers, what is surveillance like? It is a little bit different than papillary. If it's a minimally invasive type of cancer, their prognosis is excellent, both for survival and very low risk for recurrence. So I might get an ultrasound at 1 year just to make sure there isn't any local recurrence. And then by years 2 through 5, I really simply follow with just TSH, thyroglobulin, and an exam, and follow by clinically. And after 5 years, if the thyroglobulin is negative and the patient has done well, graduate them to their PCP. The thyroglobulin, however, is relevant only if they've had a total thyroidectomy. And many patients with minimally invasive disease might have had just a lobectomy alone because that was the diagnostic procedure. And so these patients would be followed with just TSH and perhaps baseline thyroglobulin levels, understanding that they're not fully reflecting tumor markers, as in the sense of if you've had a total thyroidectomy. But because the risk for recurrence for these patients is very low, clinical follow-up, i.e. based on symptoms, might be sufficient along with TSH and following the trend in thyroglobulin. If these recur, which they're very uncommonly to recur, they tend to be very good TG producers, which is why I find perhaps the baseline thyroglobulin to be still useful, even though the absolute number may not be helpful, unless it's very high. If it's a widely invasive thyroid cancer, these patients have most likely had total thyroidectomy. And so we talk about TSH thyroglobulin. I do consider a CT chest if it's not already been done. And based on the CT chest results, then determine if I do iodine scan and therapy. And on follow-up, after their initial treatments with or without radioactive iodine, we follow with TSH thyroglobulin. And I do get periodic chest CT imaging every 1 to 2 years initially, and then maybe more sporadically thereafter based on thyroglobulin levels. If the patient with widely invasive disease has only had lobectomy, we do go back and do a CT chest to determine if they have distant disease, and then determine whether we do surveillance or go to completion thyroidectomy and possible radioactive iodine. And these are really individualized decisions between this patient preference, provider preference, what the thyroglobulin is, what the histology is, how big the tumor is. And so it really is an individualized risk-adapted approach. Oncocytic thyroid cancers also have different unique, potentially follow-up strategies. These also can be stratified histologically as minimally invasive or widely invasive, depending on their degree of capsular or vascular invasion. They generally are very good TG producers. They recur both locally and distantly to the lungs, the bone, the liver. They're not radioiodine avid and really are considered radioiodine refractory. They're quite FTG avid on PET scans. So PET scan is a good tool, probably one of the best tools for staging of this disease if it's high risk. And some of these that are high risk, widely invasive, may progress more rapidly. So surveillance for these and for minimally invasive disease may be a neck ultrasound, TSH, and thyroglobulin. And if negative, consider referral back to the PCP after 5 years. The risk for recurrence for these minimally invasive with only small, few capsular invasions is overall very low. Widely invasive disease often includes TSH thyroglobulin level postoperatively with a PET CT scan for staging. And I don't do iodine scans or therapy for this tumor type. And then follow-up is usually 6 monthly for 1 to 2 years if they don't have distant disease, with TSH thyroglobulin, neck ultrasound, and either CT chest or alternating with PET CT. I tend to do an annual PET CT, perhaps for the first 5 years in high-risk oncocytic or Hürthle cell thyroid cancers. Excuse me, but also use a thyroglobulin to guide whether a PET is really needed after 3 years or so. Because if the thyroglobulin remains low and all the PET CTs have been negative, whether a PET is still needed at year 4 and 5 is certainly open and not clearly defined yet, but individualized. When we get to higher risk disease, these poorly differentiated and these tall cell variants, infiltrative, high-grade lesions, surveillance certainly is much more individualized, and it depends on whether there is distant disease or no distant disease. Structural imaging with either CT or PET CT is often the standard of care, as these are unlikely iodine avid, and if disease is found, on post-op imaging scans, you may go back and reconsider iodine scan and therapy if you haven't done it already. And then follow-up it's important to understand that imaging with CT chest or PET CTs may be considered for higher risk disease. And after 5 years, if there's no longer recurrence, we may then follow up annually, but continue their follow-up for many of these patients beyond 5 years. So I think I've taken you through the different histologies of differentiated thyroid cancer and understanding their genomics and biology and their thyroid phenotypes, and incorporating this into our risk stratification, well defined by Dr. Tuttle, and using this to both assess upfront treatment strategies as well as reassess their follow-up and reassess their response to therapy and how we do surveillance and follow-up. And when we come to advanced disease, this is really, surveillance is really dependent on the extent of disease. These patients with micrometastases may be followed once a year with CT chest, whereas these are the most advanced patients whose follow-up is dependent on their treatments. And these have an intermediate follow-up. Some who have very slowly progressive disease could be followed every 6 to 9 monthly or even yearly. Others that are followed every 3 monthly because of rate of progression. So it really is patient and disease specific and disease defined. And that's it. I finished with enough time to go over some questions.
Yes. The first one is, I'm looking at my own pathology report and see that after surgery, the report says a small p and a big T category is, which I assume is patient, and it says PT1B as in boy. And this person wants to know what the B means in the report.
So T1 lesions are basically less than 1 centimeter in size. So there's T1A and T1B, and I think the T1 lesions are basically less than 2 centimeters, and 1A I believe is less than 1 centimeters, and 1B is between probably under 2 centimeters but greater than 1 centimeter. I'd have to double check that, but it has to do with the size. Now, the other, I'm trying to look at the question. It says the question is, what does the B mean for the N1B? And N1A, N1B means where the lymph node was found. So N1A are lymph nodes that are in the central neck. That's where the thyroid is. N1B are lymph nodes in the lateral neck. That's out to the sides. So B means different things for whether it's a T or an N.
Thank you. Boy,
Yep.
very confusing. Okay. To me anyway.
Yeah.
Next question. For patients who have residual known thyroid cancer encasing a laryngeal nerve and defer completion thyroidectomy, similar to case example 3, what do you think of RAI as a treatment option compared to surgery? And how would it differ given that an intact lobe is present?
Yeah, gosh, not an easy question for that. But I think if you are thinking about radioactive iodine, you do need a total thyroidectomy, because iodine will not be very effective when you have an intact contralateral lobe. So the example of my patient, case 3, if we decided after surgery the patient had a change of mind and wanted to pursue radioactive iodine because of the disease encasing the recurrent laryngeal nerve, then completion thyroidectomy would have to be done so that we would have better efficacy potentially of radioactive iodine. So the normal thyroid is a sink for iodine. It will concentrate most of the iodine you're going to give, and we're not sure that we'll be able to deliver enough iodine to perhaps that residual disease on the other side where the nerve was. So it's a tricky situation because you'd want to have surgery carefully, and obviously we don't want to injure the nerve on the other side, and that would be difficult. So I think these cases are best seen in a multidisciplinary setting with experienced surgeons, with the endocrinologist, and with good imaging to determine next steps. The standard of care in the field is to do radioactive iodine, but admittedly, much of disease that's invasive and high risk, though the reflexes to give iodine may not be iodine avid as well. And so one really has to carefully weigh risks and benefits of next steps.
Hello, quick question. On a patient that has low risk disease and has been stable with low thyroglobulins at 5 years papillary cancer, do you, or 10 years, I'm sorry, do you recommend to stop checking blood work? What do you tell them if they're okay with that? Do you feel comfortable, or do you recommend long-standing checkups every 18 months to 2 years?
Yeah, I think that's a good question. I think, again, it depends on the initial pathology, certainly, and what the thyroglobulin is, and did they get radioactive iodine? I tend to think if you get radioactive iodine ablation, adjuvant therapy, the thyroglobulin should be 0. And when the thyroglobulin's not 0, depending on what the level is, I wonder, was it just incomplete ablation? And is there remnant tissue behind? Or is there some residual microscopic thyroid cancer that's left behind in some lymph nodes and we'll just never see it because it grows so slowly? So I would favor for that patient still doing annual neck exams, a TSH and a thyroglobulin. I think if it's been beyond 10 years and you haven't seen any structural disease on imaging, I'm not sure that you need imaging other than if clinically indicated, that if you feel something or the patient feels something, or if the thyroglobulin rises pretty significantly.
Dr. Ryder, there's been a couple sessions that we've had here regarding the different assays to check the thyroglobulin and the antibodies. Which one do you all use, or do you use?
Yeah, so we have, I think our lab is using the Roche assay, immunohistochemistry. We do have a mass spec assay for patients with high thyroglobulin levels, but I don't think it actually ends up performing well because patients with very high thyroglobulin levels, by mass spec, the TG is still low or undetectable. So I do our traditional immune, antibody ELISA assay, which I think is Roche. I don't remember. We had switched, but I think it's the Roche assay. I don't really remember which company we use.
I know that, one of the sessions talked about the IMA, the RAI, and the
Yeah.
mass spectroscopy.
Yep.
And
Yep.
so just weren't sure, I don't even know what my lab uses. So I guess for further evaluation, just need to know what would be the best one to maybe.
Yeah, I mean, I think the traditional radioimmunoassays with the standard Roche ELISA assays is what we use. There's 2 different companies, and we have the mass spec assay, and there's a different radio labeled assay that could be done for antibodies. But I rarely use that because I have found that even though we have the mass spec assay, thyroglobulin levels still end up being not useful or interpretable even by mass spec, or not reliable. So I rarely use the mass spec assay. If a patient has very high thyroglobulin antibodies, I think the TG is not reliable either way, and you have to rely on structural imaging. If that's the case after 5 years and you're trying, with surveillance, then you do neck ultrasounds if it's a PTC, because you have to rely on your structural follow-up. If it's after 5 years and they have low risk, disease, the antibodies tend to decline over time if they've had total thyroidectomy. And so that's usually a good sign. So
Okay.
sometimes the trend in antibodies could be also used as a prognostic marker.
Can baseline thyroglobulin levels of greater than 100 for those with only one remaining lobe only have other reasons for elevation than cancer? And then this person says classification of cancer was a low risk of reoccurrence and no other features of concern on neck imaging.
Yeah, so I think because we're doing more and more lobectomies for low risk disease, and I tend to not do a thyroglobulin and for some patients other than the select cases that I'm interested what the level is, because it is hard to interpret. But the size of the other lobe, whether there's Hashimoto's thyroiditis or whether there are other nodules, might impact that baseline thyroglobulin of greater than 100. It would be surprising to see the thyroglobulin greater than 100 with just an intact lobe. On our assays, an intact lobe thyroglobulin should be around 30, and when you do lobectomy, it should be maybe about half. So if it's greater than 100, it's curious, and it depends. I would look at the size of the residual thyroid. Is there thyroiditis or inflammation? You can look at the lobe that was resected, and the pathologist can look at that and say, yes, there's thyroiditis. That could be. And one could also look at the trend. Ultimately, if the thyroglobulin is high and there's concern, I would do a CT chest and make sure that it's not coming from something that unexpected, such as lung nodules that could be accounting for that thyroglobulin.
Okay, my question is with regard to surveillance of thyroglobulin, is there a certain rate of rise or a certain cutoff number that becomes worrisome for papillary thyroid cancer patients?
I guess it depends also, Renee, on whether there's been a total thyroidectomy versus a lobectomy, and you're using, and you have a thyroglobulin that, say, like my patient after lobectomy was 4s, and at least the trend was going down, so I was reassured. But if the baby
I had a complete thyroidectomy, and then I had a couple of lateral neck dissections, which showed positive nodes. Between the complete thyroidectomy and the 2 lateral neck dissections, I had radioactive iodine. And my thyroglobulin levels in the past 3 years have drifted upward from the 1.5 range to the 3.5 range. And I just wondered what your thoughts would be on that. At what, is there a certain number, like 12 or 10, or is there a certain rate of rise that indicates that the cancer is actively growing?
Well, I think the slow rise of the thyroglobulin is, number one, seemingly reassuring, and the absolute number is low. For example, in my oncology practice, where I see some of the most advanced cases, thyroglobulins might be thousands, several thousands. So to me, a 1 to 3s is generally not an absolute number worrisome. I think it does mean that there is microscopic disease. I'm saying microscopic if the imaging has otherwise been negative, and it may be a while before you see it. The question is it just in the neck, or could it be small volume disease outside of the neck? And so if it continues to trend up and reaches the 5s and 6s without any evidence of disease in the neck on a good ultrasound, then it might prompt a CT chest to assess.
I have a question about RAI for the second time. I had a hemithyroidectomy in December of 2020, and the next day the surgeon said, I recommend you remove the left side as well. So I had a completion a week later. I did RAI, and now I have a recurrence in a lymph node in the central neck. I just had a surgery. 9 out of 13 lymph nodes were positive, and RAI is recommended again. Just wanted to know what your opinion on doing a second round of RAI is.
Yeah, I can answer in general because not knowing all the details, but thank you for that summary, Deborah. But I think if you, in general, when I see patients with questions about radioactive iodine, if there's been a recurrence or progression of disease after a dose of radioactive iodine, then I'm not generally optimistic that more iodine will be of help. And that I often go on to surveillance at that point.
Thank you. And also, is there any kind of long-term side effects doing 2 rounds of RAI?
Certainly, we talk about cumulative effects of radioactive iodine on your salivary glands. And so patients who get, somewhere around 75 millicuries or higher, that's the threshold to damage salivary glands and could lead to dry mouth. There's risk of damaging lacrimal ducts, so you can get tearing. And of course, at over 500 millicuries, we do think and know there's a rare risk for leukemia. That's incredibly rare, but as the doses of iodine exposure are higher, that becomes a risk.
Hi, I had a isthmus removal, and they discovered the tumor that was there was Hürthle cell cancer, and then they did a total thyroidectomy. And I also have the antibodies against the thyroglobulin. And this surgery was 3 years ago, and now I have like a lump under my left arm, and my right shoulder blade is swollen. What kind of follow-up should be done if, I think there's a problem with thyroid issue?
Sure. Hürthle cells, now called oncocytic thyroid cancers, really, there's more and more data about what drives these and understanding their biology. We understand they're very different than the traditional follicular and papillary thyroid cancers. So with that, so things for me always go back to pathology. Was it a minimally invasive? Was it widely invasive? Was there blood vessel invasion? Those things are important because they do predict recurrences.
I think they said it was encapsulated, but for some reason the surgeon was on the fence, and he said, I want to take the more aggressive stance and do the total thyroidectomy. And then I did have radioactive iodine.
Right. So traditionally, historically, we've been giving radioactive iodine, but my approach has changed on that because unfortunately, these don't respond well to iodine. So if there's question about recurrence of oncocytic or Hürthle cell thyroid cancer, I think, and if you can't rely on the thyroglobulin, and if the antibodies are going up, that would be suspicious as well, then I would do either structural imaging with CT or consider a PET scan at least one time to have reassurance about whether there is or isn't disease.
Should it be a PET scan that includes the lungs?
Well, all PET scans are whole body, so it would include the lungs, yeah.
But if they do a CT scan, that wouldn't necessarily include the lungs, right?
No, there's CT of different body parts you can do. You can do CT of the neck, you can do CT of the lungs, you can do CT of the abdomen.
Okay, so you recommend I should do a PET scan?
So I think I would see your doctor, Christine, and get evaluation, for what these lumps are. Can they feel them? Sometimes you could do an ultrasound for where the lump is, and they could do a biopsy of that. They could even do a plain x-ray for the shoulder. But ultimately, if there's thought that there's high risk type of oncocytic thyroid cancer, which it doesn't really sound like there maybe was, then that may or may not push one to get ultimately a PET scan.
For oncocytic, when doing CT lung, do you use iodine tracer?
So I do not for oncocytic thyroid cancers. There was a recent consensus paper that was written by many experts in the field. I was one of the co-authors on that paper, and we really talked about the biology of oncocytic thyroid cancers, that they're driven not by commonly nuclear mutations, although they have things like RAS mutations and mTOR mutations, but they're driven by mutations in what we call the mitochondria, which is kind of the engine of the cell, which is really unique. this biology and genomics probably accounts for the differences we see clinically. And since in the field, we've known that the majority of oncocytic thyroid cancers or Hürthle cell thyroid cancers do not concentrate iodine, we've really moved away, and in this paper have suggested that it's probably not routinely recommended to do radioiodine as your only diagnostic scan for patients, because this disease is often refractory. It won't show up on an iodine scan. So more often than not, we are doing either CT imaging of the neck, the chest, the abdomen, and pelvis, or a PET CT if there's a high risk oncocytic or Hürthle cell thyroid cancer.
Okay.
Hi, yeah. One is a comment. I'd like to ask Dr. Ryder to please comment a little bit on all of the negative side effects of external beam radiation once a person is 10 to 15 years out. My husband has found a lot of them, and I felt like we were I think we still would have absolutely opted to do it, but I felt like we were unprepared of what to look for in his future. And I'm also wondering if you have any experience or recommendations now for continuing with COVID boosters, which with his fifth one, he developed a vocal cord paralysis in the only working vocal cord. And we are uncertain to this day if that was possibly from the COVID booster. There's some small literature about it possibly causing vocal cord paralysis, or if it was something for the gift that keeps on giving, the external beam radiation causing it. But I'm doubting now that it's that, because actually the paralyzed one vocal cord came back. So that's good, because the other one was severed when the right laryngeal nerve was sacrificed in 2010, because the cancer had come back wrapped around it.
Yeah. So I think, Robin, external beam radiation therapy is very difficult, and it is a chronic process of living with the ramifications for that. And it's one of the reasons we try to delay external beam for as long as possible with our patients. And it's why newer modalities with things like proton beam are being considered. And in Mayo Jacksonville, we're developing a carbon ion radiation therapy, which sounds very exciting, and it has the opportunity to deliver very high dose radiation with perhaps less scattering or less toxicity to normal structures. And the long-term sequelae of radiation, we see it it's also patient independent or patient specific. There are some patients that rebound very well after IMRT, 60 gray to the neck, and there are other patients that progress through to swallowing difficulties, most commonly, lots of thick secretions, and difficulty with coughs and aspirations being probably the two most common. So I can't list everything for you, Robin, because it is patient specific and different, but it is a tough treatment. I do agree. And I'm hoping that future treatments will, with our treatments and some of the things, the curative treatments that are coming on the horizon for future patients, might help us reduce the need for this. But it is, I think, very carefully about external beam in my patients because of the many complications that we see. And in terms of the COVID booster, I agree. I'm not sure whether COVID itself could have impacted the recurrent laryngeal nerve function or not, or other systemic treatments that your husband may or may not be on that might influence the function. We typically tell our patients there's no absolute contraindication to the COVID boosters with advanced thyroid cancers. And so I think it has to be individualized, certainly, Robin, in your husband's case, based on what happened after the most recent booster.
Side effects from levothyroxine, palpitations, fatigue, anxiousness, etc., for people with hemithyroidectomy. And I think this was still this person's said, and only taking 12.5 micrograms of levothyroxine.
Yeah,
So
I think that's a tough one. I think with that small of a dose, as an endocrinologist, I would look for other reasons for these symptoms, especially if you have your other lobe in place. the other lobe may still be functional. I'm not sure what the TSH is, but generally, if with the other lobe in place, if the TSH is really under 10s, that lobe is working, may not be 100%, and if levothyroxine, or if you're having symptoms, I would follow up and look for other reasons for those symptoms, because 12.5 is not typical of what we would expect to have any symptoms at all.
Okay.